All right, well, let's go ahead. I think we'll go ahead and get started here. We'll
Sure.
have people joining us. We'll also have this recorded and we'll post that afterwards for those who can't make it today. And so just as always, this is an interactive discussion. And so please post your questions in the chat. You can always raise your hand too if you want to, or unmute and ask your question that way. So today is our second installment of focusing on hormone replacement or menopause hormone replacement therapy. Today we got Dr. Carrie Winnicky with us. Carrie is the chair of OBGYN here at KU. She is from Dyersville, Iowa. So, small town connection there in rural Iowa, home of Field of Dreams. So if you guys want to talk about a great movie where it's set, you can actually go visit Carrie's hometown. And so we will not list off all her credentials and all her accolades because we want to spend the rest of our time kind of diving right in. So we're going to start with a very kind of classic case to kind of launch the discussion. But I think as always, we'll kind of take this off kind of in the direction that the audience wants us to. So all right, so Carrie, first patient, I guess the only case we brought today, 52-year-old woman presents to the clinic reporting severe hot flashes and night sweats that began approximately 8 months ago. She describes waking up 4 to 5 times per night, drenched in sweat, requiring her to change her nightgown and sheets. During the day, she experiences sudden episodes of intense heat and flushing that occur 10 to 12 times daily, which have become embarrassing during her work meetings. She reports that these symptoms are significantly affecting her quality of life, her work performance, and her sleep. Her last menstrual period was 14 months ago. She also mentions vaginal dryness and discomfort with intercourse, as well as low sex drive, which has affected her relationship with her partner. Her medical history is pretty benign, just some hypertension that's well controlled. Labs, everything kind of pretty straightforward. And so I think kind of just to start off with, as we have a patient presenting to our clinics like this, how do you approach that initial evaluation of perimenopause, menopausal women presenting with vasomotor symptoms? What are some of the key history questions you're looking at? And then any testing or things like that that you might entertain?
Yeah. So I think, I mean, in this situation, like I said, you gave me a great case, an easy case, right? And so I always, so the first thing is that I rarely can, and I don't, none of us do is address these during an annual exam because it really takes longer and you have to delve into. So I will give them some information, give them maybe a way to chart their symptoms, and then we set up a discussion outside of because it you can't cover all of this in the time that we are supposed to be doing a wellness or an annual general exam. So let's say this person like is now coming back to me. Some things that I kind of go back to is, and I say, I don't want to. Some people get really upset when I talk about periods because they think I'm gonna not pay attention to their symptoms. But I say I need to go back and just tell me like when was your last period, right? And so, because that just helps me kind of ground where they're at in the continuum. So, in this situation, it's been 2 years. So 2 years ago, no bleeding, confirm that, right? Because it's very different. I approach a patient differently in perimenopause than in menopause. So in this situation, it's been 2 years. She hasn't had any bleeding. She's in menopause, right? So she's 52. Average age in the US is 52.7. 90% of all of our patients will be in menopause by age 55. So there's nothing abnormal or unusual to this initial kind of starting presentation. I would then delve into a little bit about her hot flushes, night sweats, talk a little bit more about them just so I have kind of an understanding. Whenever, people tell me about the night sweats, I want to know, can I fall back asleep, not fall back asleep, these sorts of things. And then I probably would go into this one a little bit of has she tried anything? Because, people have come to me with all sorts of things and I want to make sure I know what they've tried, haven't tried, brought with them to that visit. Um, let's see, vaginal dryness. That's another, you have that on here. And if you want me to go in a different direction, stop me at any time if there's
Oh,
questions.
you're
So
doing great.
vaginal dryness, that's a great question. And I want to know, so when is it painful? And I'll get things like, well, I'm not sexually active. And I said, that's okay. We don't need to have sexual activity to have vaginal dryness, right? Like I have plenty of patients that are sitting there in front of me that are complaining about irritation, dryness, itching, frequent urinary tract infections, getting up in the middle of the night to go to the bathroom, all of these things that have nothing to relate it to penetrative intercourse. So, I try to delve into that a little bit more so I understand that. And then the low sex drive. And that's probably one of the things that I say, I hear you, but that's going to take a lot of talking. So can we come back to that?
Mhm.
It's hard for me to address low sex drive on top of a lot of the other menopausal or perimenopausal symptoms at a first visit. And I also, when we'll get down to treatment options, like I think of some of those things on top of or in addition to. So I might delve into this really quickly, not quickly, but a little bit more superficially than I would at the first visit, some of my other things. So, is this new for you or has this always been a concern? Do you think anything else might be contributing? And then I also come back to pain because a large portion of our patients that have vaginal dryness and pain, brains are really smart. And so if something has hurt repetitively, the brain would not tell you to go jump into a burning house over and over again, right? And so we make sure it kind of delving through if I think there's a pain issue to that.
Yeah. I was gonna ask, so do you ever start the visit by asking people like what are you hoping to, what are you hoping that we address during this visit? Like, do you get their sense of like, are they really interested in hormone therapy right out the get-go? Do they want to talk about non-hormone options? Like, do you assess kind of what they're trying to get out of the visit before you really delve into everything?
So I said, what can I do for you today? And I think, that's because like I said, I do see them in most of these patients in a different clinic. And so they take off from there and they tell me. So either I want to know if hormones are an option for me. I've been told by doctor, this won't happen, or I know I can't take, or I don't want to take, what else can I do? And so again, I probably have a little bit of a leg up there because my patients are coming to me knowing that they're seeing me in the midlife menopause clinic.
Okay, that's fair. Yeah, I usually have the visit, like right at the end of the visit, they're like, also I want to talk about getting on hormone replacement. And I'm just like, oh, no, we can't do that. And then it's difficult because they're here, they want to
Mhm.
talk about it, and we just don't have time. It's so hard to get people in and people who are comfortable managing it. So this is why we're doing this. And so do you
Yeah.
a way of stratifying someone like nicely into like, oh, well, maybe we should try non-hormonal versus hormonal options. If they want hormonal options, do you jump to that, or do you ever encourage them to do non-hormonal if all of their like kind of risk factors are equivocal?
So I think it's really are hormones safe, right? And so if the risk benefit is high, then I am going to talk first about non-hormonal, um, and then really go through the risks and try to outline why I think the risks are better than benefits in that person. If the benefits outweigh the risks, I'll say I think that we can have a further discussion about hormones, or would you like to, or we can talk about non-hormonal options. What are you interested in today?
Let's talk a little bit about the risk, Carrie. So when you're thinking, okay, so this might be a person, hormone replacement might help with some of the vasomotor symptoms, I would think, right? And so what are you trying, what are some of the major things you're looking for that would tell us that is an option that we should steer clear of?
Yeah. So a couple, I want to just clarify that when I'm talking today, I'm not going to talk about premature ovarian insufficiency or early premature menopause, right? So under 40, that's a completely different sort of discussion point because the risk benefits of that patient are very different than someone that's after the age of 40 and 50. So just to make sure like that they live in a different bucket over here. They have pretty clear benefits from the addition of hormones. So just think that. As far as risks, so when I talk about risks of hormones, well, I guess I can go two different ways. Contraindications, are you talking about like people that we can't give hormones to? So, contraindications would be the first of which would be unknown bleeding. And I probably work up too much bleeding, because I think that it's so much easier to work it up before we start than have continuous irregular bleeding and not know if it was something that was there prior or that we caused with the addition of hormones. And so when we start hormones, I tell people if they haven't had bleeding in a menopausal, you can have some bleeding and spotting. I typically tell people 4 to 6 months can be normal as long as it's not heavy like a period. So, but a contraindication would be some unknown non-vaginal bleeding. Estrogen sensitive positive cancer or neoplasia, right? And that can be breast, uterine, vulvar, wherever that might be, but any estrogen dependence would be a contraindication. Prior coronary artery disease, MI, stroke. Personal history of VTE or PE. Now I kind of smile at this one because I think that is an area where we delve into a little bit more. So was it provoked or unprovoked? What was the situation around it? Because certainly some people do believe, and we have patients that had provoked DVTs on hormone therapy. So try to get to that one a little bit more. And then liver disease could be something that we have to consider, especially the route of that estrogen would be important there. But those, I think, are the big contraindications.
So if they have any of those, then we would want to be avoiding or hormone replacement is what you're saying.
Yeah, and again, like I said, the personal history of VTE is something that we have counseled and have patients on hormone therapy for.
Okay. I'll go ahead, John.
For all of our patients, we all have CT scans, abdomen, pelvis, chest, and there's always minimal atherosclerosis of the coronary arteries. Or, I mean, is this clinical ASCVD that you're talking about that really pushes you away from it? Or like, do you look at these scans and say, actually, there's minimal or moderate, and this is where I really start to get worried that you're at a higher risk for a coronary event from this?
Yeah, and it looks like we got 3 chats up, and I think a lot of these are on the same sort of thing. So I start with mostly everyone, right? Like my note template has the ASCVD risk assessment in it. And so that's the easy way for me, the non-primary care doctor, to start. Right. And so I'll start with what I look for that. So again, and it's not perfect. Right. And there are things that I'm like, oh my God, how can your risk score be so low? Because I'm worried about this, this, and this. Right. But if I'm under 5% risk, I consider that low risk. And I think that patient might be not only an option for, but I even could discuss an oral option. Okay. If their 10-year risk assessment risk score is between 5 and 10 or 5 and 8, depending on sort of what you want to look at. And I probably go to 5 and 8, but it is intermediate. And so in that patient, I would only do transdermal. So patch, gel, spray, vaginal ring. And then if greater than 8 to 10, I am going to have to need some other risk assessment. And for the majority of the people, if they haven't had it, and I see there's some questions over here as a cardiac calcium score we have now. And it's, I think that's evolving, especially like in our world. We had a whole lecture on it at the Menopause Society, and it was very funny. We are probably much more conservative as OBGYNs with what we're looking for, et cetera, than I think probably some primary care cardiologists are, but that would be my next thing. And I also reach out to frequently. I mean, there's people here that I text after every menopause clinic and be like, hey, what do you think about this? Like, let's work on this together. Like, if, should they be on a statin first? This sorts of things. So is that what you're looking for?
I look at these scans and we'll see a blip of calcium on a coronary artery calcium score. And then it's just like, well, what do we do from that standpoint? If the score is 2, it's like, well, they're 52. Of course the score is 2. That's not overly surprising. And then then a lot of fear plays in, and then we don't get anywhere. And so that's something. And I think Bree had some comments on, even in the case of an ASCVD event, can we still consider transdermal with a risk benefit discussion? And I think we get more into that later. We can dive into it now, kind of whatever.
And so I'll jump to both of those. So there is sort of roughly, again, and we use, I feel OB Jones use rougher things. So, yeah, I think less than 100. I want to so zero's easy, whew, right? So less than 100, I want to reach out to their primary care doctor and consider a lipid lowering medication. And in that situation, transdermal, you typically is going to be okay. If we go to 100 to 300, and I mean, that's what the literature says. I get worried over 100, but aspirin lipid lowering, and again, some shared decision making could still be on transdermal.
And this concern with cardiovascular disease, now, is it associated with progressive coronary disease, or is it associated with actual like plaque rupture? You know what I mean? And like
rupture. It's the instability that it causes.
It's what?
It's the instability that, it's like the estrogen causes the instability to the plaque, so plaque rupture.
Okay, that's helpful.
Basic pathophys, I do not remember.
Yeah, okay, yeah, me either. It's
Okay, let's see. Can I make sure I've answered these? Okay. Okay, I think I answered the first one. If not, please let me know. Because this kind of came about from that. I was like, that your guys' chat questions from that last lecture. Like if we could have addressed that was so good. So I'm hoping I can answer some people. Free calcium score more chronic disease without. Okay, I think I answered that one. Okay, so known cardiovascular disease. So the quick and dirty answer is that the easy way to think about this is that if you have any concern or questions, it would be a transdermal. The transdermal doesn't erase the risk completely, and so we don't want to ignore other contraindications, etc. So the answer is everyone shouldn't be on hormones as long as it's transdermal. But we do have some smaller studies that look like that do show that the risk is less in a low risk patient using the transdermal route. And again, I also want to just remind people that I feel like everyone is on patch, which is why the patch shortage is occurring. Like, I don't know how many messages you guys are getting, but I probably get about 100 a week. But just remember, transdermal is gel, spray, and vaginal ring as well. Rachel, I will send to these guys our list of resources. It changes, and for low libido, they're on there as well. And if I think, a lot of this is driven by social media, and I will tell you that our list of resources has changed. So I call it jumping the shark, and there are a lot of people who started off, I think, as really good resources, even on social media, and they have jumped the shark. And I call it jumping the shark when we do a lot of things, and I have to fully admit, I do a lot of things that I don't have the evidence for. But I think that when we fail to tell people that we don't have that evidence and act like we do, that's when we get people into trouble. And so there are a ton of people out there that, the other thing is medicine, especially OBGYN, is not that exciting. And so when you are pressed to be on social media and Instagram every day, I think you have to make up some stuff in order to find to keep doing that. And I see some of that stuff. So our resources have changed, but I will send those out to you. So Brianna, the benefit and risk, it's always going to be a benefit versus risk. The question is, I think, is what is the event, and how you would use that in your discussion. I think yeah, and so not wanting intercourse, but HSDD by definition is your own guilt, not your partner's guilt. So if it's impacted by the person, that would be your HSDD, which testosterone is indicated for in postmenopausal patients. There are also 2 additional medications, Vyleesi and Addyi as well. Do you want me to keep going with the questions, or do you want to go on with the case?
Yeah, we can dive in. We want to lean into what is on everybody's mind.
Well, sorry, can I want to go back
yes.
Just do just a little 1-minute topic on just like the low libido and what you're talking, just elaborate
sure.
more on that.
Yeah. So low libido. So again, I always try to, I hope it's because of pain. That's the easy one to take care of. right? So I pull that out to see if I think it's due with that, to see if I can help with vaginal estrogen, pelvic floor physical therapy, those sorts of things. If it's not, and I think it's more than that, I first of all talk about it's multifactorial ton. But, and so, there are a lot of things. So, how's your relationship if it's a relationship, right? So, how is your relationship? Has something changed? We look at medications. Medications can cause impact on libido. And then if they're interested in medications, we talk about also sex therapy. We have a sex therapist, also give them some resources. If we come back and want to talk about medications, then the medications that we talk about are testosterone or Addyi or Vyleesi. So, and then I give them those information. I rarely will prescribe on the first visit because I want them to go out and read about these medications. So Vyleesi is an injection, Addyi is a pill. One is as a sort of a PRN or on needed basis. Another is you just take daily. And so those are there. Of course, everyone now, the rage is testosterone, right? And so, the first thing I say is that it is what we use from the Menopause Society, and ACOG is for postmenopausal. ACOG recently included perimenopausal low libido. I only use FDA approved medications. And so that would be, I prescribe in here in the United States, we must prescribe a male dose testosterone, and we dose it for females, which is 1/10 of a dose. I also typically, by the time if I've had seen a patient, I've had a discussion about why I don't do levels. And so then I have to say, but this is the one case that I do draw blood work. And the reason I do blood work is because we don't want to have you start out at a female super therapeutic range, because I don't want to get you higher than that. And so I will do there's a really nice Green Journal article, and I can send it to you guys to share as well, about how to dose and how to do the testosterone. But you do baseline LFTs, total testosterone and sex hormone binding globulin. And then as long as we're not, above 80, then I would start the testosterone, and then it tells you how to follow it. And again, I'm not following it to get in a magic number. There is no therapeutic, there's no magic number. I am only testing to make sure we're not super therapeutic, because we do know that super therapeutic can be higher risk of some irreversible changes with testosterone. And the big one here is voice changes. So I had a patient yesterday who had been on HT from another provider, but wanted to talk about testosterone. And like, she's an actress and a singer. And she's like, well, there goes my career, And so after a discussion, she's like, yeah, not worth that risk.
Interesting.
So,
okay. Yeah, and I
yeah.
think there's a lot of questions around this. I think we lean into this a little bit because I think part of, we're seeing a lot of more women coming in on testosterone from other clinics and stuff. And I think this is an area, or I'll speak for myself, that I've just felt like I don't know enough about this. I mean, I think we're quite comfortable and used to prescribing testosterone in men, and so it's just a little bit of a new era for us. And so with the testosterone, you're saying when you're checking it, it should be under 80. Did I hear that right?
Well, so yeah, so that would be your super therapeutic. And I would say when I want to start, yeah. And my goal would be 80. If they are between 80 to 100, I might tell them to back off, but I would not stop them, but I do not want them over 100. So people that are looking for resources, Professor Susan Davis out of Australia is the testosterone guru, 99% evidence-based, amazing woman. She puts good stuff on social media, and is really the person who has been done most of the testosterone studies and work. She's great. But they also have a female approved testosterone in Australia. So
I went to ACP 2 years ago. I went to a talk about testosterone, and he briefly mentioned, he was like, Australia is the place where all the testosterone in women is happening. And he was like, and this is where they have their FDA approvals over there for testosterone in women for multiple things. And so, that's really helpful. So, when women come in and say they're already on a pellet or something like that, this multi-hormone pellet, and you check a testosterone and they're like, oh, I feel great, and their testosterone's 140, what types of things are you talking through with them, saying hey, these are the things that we can expect from it being super physiologic, so we can help dissuade them from being on these high doses?
Yeah, so a couple things. So if they come in on compounded therapy, I first start off by, and I have patients that come to me and I will say, before we get started, I just want to let you know this is what we do in our clinic. And then that said that I think that FDA medications are important. I liken it to a chocolate chip cookie. So, a compounded hormone is like making chocolate chip cookies. If I might have a recipe in front of me, but if I'm having a bad day, I want to add the entire bag of chocolate chips. If I follow the recipe, I add a cup, right? That's versus Chips Ahoy, which, although, every cookie has 14 chocolate chips and weighs, 6.2 ounces, although that's boring, that's what you want in your medication. And so, I don't do compounded therapies, 99% of the time. And we could talk about those what ifs as the one offs later if you want. But, and so when we talk about pellets, the thing about pellet or injection is it takes you up to the top of the mountain, right? And there's no titrating. It takes you up here. You don't go to Mount Everest and being dropped off at the top of Mount Everest. You slowly climb up so you can acclimate. And I think that that's an important part too. Um, So, if a person comes in and is interested in transitioning over, I find out when their last injection or pellet was placed, and then when they would be due for a replacement, and then I will check a level at that time. If it is super therapeutic, then I will have them check again like every week until it comes back to a range that I would feel comfortable prescribing with. Does
What
that
formulations so you don't do injections? Like what specific formulations do you typically go to when you do prescribe this?
So these are FDA approved for male because I think this is for
Yeah.
CME, right? So I have to be clear here. FDA approved for male. So we androgel or testim.
Uh-huh.
So testim comes in small tubes, 5 cc tubes. And there's a great YouTube video about this, but you basically have them get a 5 cc syringe, draw it up in the 5 cc syringe, and they dispense a half a cc per day. Now, most people, after a couple times, they will get to understand what a half a cc is like, and they probably don't want to or don't need to draw it up and do it every time, but it's a good starting point. The androgel comes in those small little like ketchup packets, and it's 1/10 of a packet too.
Okay. Okay. Interesting. And does anything change with this with testosterone in someone who's perimenopausal?
Well, so the Menopause Society would say it's only for menopause,
Mhm.
post-menopause, or menopausal low libido. The ACOG Green Journal Review did include perimenopausal low libido in their reasons for prescribing. So, but otherwise, no. But we don't prescribe for fatigue, muscle mass, these sorts of things, which is the a lot of what social media has out now. But we try to stay away from that at this
Rebecca,
point.
you have your hand up.
We've lost our hand raise. I think the testosterone I think brings us into what I have because I'm middle aged, my patient panel is 40 to 50. And what has exploded in the last 6 months is perimenopausal hormone replacement therapy, which they're getting at their Medi clinic, their aesthetics clinic, their GLP-1 clinic. And so it's all compounded. And, anecdote last week, new patient visit, 38-year-old female, postpartum, not breastfeeding. She's 6 months postpartum, not breastfeeding. And she came in on progesterone, testosterone, and a GLP-1. And that is routine and sort of asking me to take over. And so I start to question, well, I feel more and more comfortable because of my patient population doing menopause hormone therapy. But this question, the definition that our patients are seeing and inundated, whether it's social media or the non-traditional medical clinics that are everywhere, whether it's for weight loss or aesthetics, like, what is my definition? I don't have a working definition of perimenopause anymore. And I feel very uncomfortable. And I want them to seek that type of care in my clinic, and not feel abandoned or not listened to. But I find that I'm at like my limit of what I'm comfortable with and what my knowledge is. And so I'm just curious about that perspective of, it's often starting with progesterone at night, adding testosterone for the libido, and then the estrogen comes in later. And then where does the traditional OCP come in with that? So thank you.
Yeah. Got it. So we can jump to perimenopause. Okay. Peri is a wonderful definition of the time before menopause. Really helpful, right? And then to add to that is really there is no blood work or blood test that is really helpful at all. I mean, the likelihood of it helping you is rare, right? Because by definition, it's up and down and it's chaos. So, the 4 to 7 years of perimenopause is average in the US. So what I tend to say to people is that, so again, average age of menopause, we said was 53. So, and that's average, right? So if you think about bell curve, it is, it can be extending into the low 40s, upper 30s, perhaps. I mean, depending on where you're at. And so the question really to me is that what are the symptoms that they're having? Because I do think that, I usually start this talk by saying, in 1997, when the WHI was enrolling women, I was a junior in college and I was eating, canned carrots, barbecued, chips and beer. And a lot's changed since then. 2002, when the New York Times came out, I was a third day in my intern year. And so I never prescribed hormones, right? And so here we are. And I think during that time, women became resourceful. And what did they do? They were driven to these other places to receive, frankly, suboptimal care. And so, I mean, it's not uncommon. You ask some of these women how much money they spend, it is crazy. For the labs and for what they're getting. And my favorite is progesterone cream, which they are absorbing close to nothing for. But so, your point is well taken, right? And so at some point I say, so, Perry, here we are. I can't test for you. What symptoms are you having? And it's hard if they come to you on things, but what made you start this, right? So what are the symptoms? Is it mood related? Is it irregular menses? Is it rage? Is it anxiety? Is it hot flushes, night sweats? Is it, we could go down about 140 different things. And so the question is what were the symptoms that caused someone to start? And do I think that the medications that they are on are helping? Or are there other things that might be more helpful? And so I try not to say, well, that was the wrong thing, but try to redirect them if there was something better. Case in point of this morning, a very similar patient to you, 38 years old, with an IUD in place, had an estrogen patch and was having some still luteal phase symptoms because an IUD doesn't prevent ovulation. And so they gave her prometrium, micronized progesterone, which does not inhibit ovulation. So we're just adding things on because that's what, the easy thing is that's what everyone wants to be on. But we aren't looking at the root cause is that she's having, ovulation symptoms. So I think kind of getting back to that as a little bit. So I try to go back to what made them or what drew them to start, those medications. Unfortunately, I find in those med spas, they rarely prescribe a medication for a symptom. It's these compounded medications with estrogen, progesterone, and testosterone in them. And so that's even like makes less sense. Like, what were you really trying to help? Does that help answer?
Is there ever a time where someone like an age where they come in and they're like, I think I'm in perimenopause, and you just go, well, let's talk about that. Like why that's probably not the case or maybe is, and like let's do more evaluation and like figure this out.
Yeah, I mean, so again, I come back to the periods, right? And so, like, tell me about your hormone cycles, right? And tell me what they are. And then the other thing is, remember before this became the rage, someone said on this, right? We still had PMDD, and so I feel like also like some of those things are now just being diagnosed or labeled as perimenopause, right? And so again, like, how are your symptoms? Are they cyclic? Are they not cyclic? What part of the cycles are they part of? And so, I think perimenopause has come synonymous with any symptom related to a change of hormones. instead of being more specific about like the changes of perimenopause, if that makes sense. I think Marie, you had asked like when does an OCP come in here, and so for me, especially in early perimenopause, when I think that, I am finding, what I would say is our bodies crave regularity and schedules. And so in peri, the chaos of peri, the inability to control the cycles leads to highs. So you can have something called a loop cycle. So we double ovulate. So your estrogen, I mean, people have probably, had drawn a blood level and you're getting like a 280 estradiol level, right? So you probably ovulated twice. And then you go next month and you don't ovulate at all. So you went from estradiol of 280 to your estradiol of, 30. And then your FSH changes in between there. And so if we can get them to not have that and sort of level them off, I think that is helpful for a lot of perimenopause. Now, some people, I mentioned that too, and I just become the bad person because, again, on social media, what does people say in that OCPs? Doctors don't know anything, and we're giving out OCPs. And so, even if a person like had a hysterectomy, still ovary, so they still are perimenopausal sort of in those symptoms, I would be like, I know that OCPs aren't an option for you, but let me tell you on why, if you had a uterus, I would be talking about this because it's those coffee circles or the mahjong groups that I need people to help me like, make an OCP an okay option. Of that, it also in their 40s is the second highest spike of unintended pregnancy. And so the other thing is people forget they can get pregnant. And so prometrium, micronized progesterone, is not a contraceptive. And so just a reminder of that as well. But I have quite a few. I mean, most patients in peri, especially early peri, my first recommendation is a type of combined oral contraceptive. Now, there are oral contraceptives that I like better in that time period, but that is usually my first recommendation. And I also do, dependent like how far back I am in my, schedule that day, but talk about how I really wish we wouldn't have talked about oral contraceptive pills. Like, why couldn't we just call them, combined hormonal medications? Because, well, what do you mean? I don't need contraception. I know you don't need contraception, but what you need is estrogen and progesterone. And this is the best way for you to get it.
Yeah, makes sense. Marie, does that answer all the questions you had on that? Or so we have a question in the chat. It's a different topic. Are you cool with that? Okay. So
Marie, did that answer your question, or do you have something more off of that?
No, I think it does. I think it's that pressure to feel like I have to prescribe something before I would be ready to, and so I think this gives me the tools for the conversation. Because you start to question yourself, and sort of there's a competitive dialogue that's happening outside your own dialogue, and being armed with the conversational tools is super helpful.
yeah, exactly. Okay, so let's see. We have a question in the chat here, going back to our patient with menopause.
Yes, actually, before you get there, I did address this insurance approval one.
Oh yeah, go for it.
Yeah, so this is so my nurses love PAs. Humor. And so yeah, we have some set language that we've used, and I know that what the PAs are going to be looking for, so I will try to be very clear about what they've tried and why I cannot use things when I write the note. But I will, and also like randomly it will work. So I always tell them like, let's try for the first time. I also tell them GoodRx, PhilRx, BlinkRx, and HRT Club. I will tell them right from the beginning, like, these are options. As far as testosterone, I tell them we don't submit to insurance. Like insurance isn't going to cover this. So you need to like find be prepared to pay or start looking at these other options to get the medications. Also, we are hopefully going to be enrolling in a PCORI that will be the first head-to-head SSRI versus estrogen for VMS symptoms, but it's just being reviewed now. But that's my fun thing for that.
Does Mark Cuban's pharmacy sell any of this?
Yes.
Okay.
I know estrace, like the big one for me was like estrace cream for the vulvovaginal disease. It's like $14 for a tube or something like that. It's just so much more affordable.
Yeah.
Yeah. Okay. Yeah. Back to menopause. Yes. Yes. Okay. Recent patient.
Do you want?
Yeah. It's
Okay.
great.
So I have a 62-year-old female who went to an outside hormonal clinic, no sweats at all, very vague symptoms, decreased energy, fatigue, arthralgias, maybe some genital urinary symptoms. She got put on 225 of progesterone every day, not cyclical, and testosterone on her thighs, very low dose, a Vivel dot patch twice a week, which is appropriate, and some T3 with history of thyroid cancer in the past. She's now bled 3 cycles, and they told her that was fine. And she said, like, legit periods again. So I'm seeing her for a physical, and I'm like, wait a minute, this doesn't sound good, right? So I get a pelvic ultrasound. I say, when's your next visit? When do they do labs? What are they looking at? Go back and tell them you need a pelvic exam. You might need a biopsy. I'm not sure. They said they don't even do pelvic exams.
No.
Okay. But kind of freaked me out, right? So I'm like, this doesn't feel good, especially, and she doesn't feel better on the hormones now. So now she's bleeding and she does not feel better, and they seem to be kind of high doses. So, if it's a cycle, do you have to do this abnormal uterine bleeding workup or not?
So if on continuous, you would not expect them to bleed. So when I talk about bleeding, I'm talking about like panty line or spotting, right? And if I tell them it's like a period, I need to know. So
Right.
if that happens once, um, and if I know the person has had, recent exam, recent pap smear, these sorts of things, I probably after the first one wouldn't do anything. And if it continues or comes back, then I would, if it's that heavy. But if they have some spotting, so people call in, I had a little bit of spotting and things, that first 4 to 6 months can be normal, but not heavy bleeding like a period. If it's cyclical, and you mentioned it was continuous, but if it's cyclical,
Oh,
that is made to induce a period. But multiple things you said in that make me worried for her, right?
yeah, right.
Yeah.
Yes.
So on that case, she needs an exam to make sure she doesn't have some fungating mass or something that's bleeding from, right? Because not all bleeding is from the same place,
Yeah.
right? And then if not, I would do an ultrasound. And
Okay.
I would tell, and if she's not improved on her symptoms, then
Right.
she needs to stop some
Okay.
of that other stuff that she's on.
So I'm fine getting I mean, I ordered the ultrasound and I just said, well, I'll do a pelvic exam if they don't
Mhm.
do that,
Yep. Yep.
okay. And then stop them if she doesn't feel better, right?
Yeah. And if she wants to talk about hormones, I mean, there's other
Yeah.
things just probably that she
Right.
doesn't need to be on all of those things and those doses.
Okay. Thank you for that. And the other thing is I'm commonly seeing them not do the progesterone doses are higher than standard, right? So either 100 a day or 200 for 12 days. I'm not seeing that. I'm seeing 200 every day when they come and see me. And then they're complaining about things. So I'm like, why don't you go back to 12 days? Is that appropriate?
Yeah, so there are a couple different things. So if you look up, in the thing it's 100 or 200 cyclical. But what we know is that so the bad part about prometrium is it's a weaker progesterone, being bioidentical. And so it is not uncommon that we need more prometrium um, to with abnormal to stop the bleeding. So the most common reason that I have a patient that isn't tolerating or I need to switch off of prometrium is because of spotting. And so it is not uncommon for us to go up to 200 continuously. I don't have anyone on cyclic progesterone. Most people want to get rid of periods.
Okay.
And so if I have someone that has bleeding and I've worked it up and ruled it out to be benign, I will first consider to go up to 200. Now, a great trick is to split that up into BID dosing because prometrium actually has a short half-life being, quote, bioidentical, end of quote. But unfortunately, prometrium, as most of us know, our patients tell us that they get some sleep benefit out of it. So a lot of people can't tolerate a BID dosing to it. So
Okay.
then if they can't tolerate the BID dosing, they still have spotting, then I would switch up the progesterones and going to a progestin. Now, again, that's a different little risk profile, right? Because that's where we think that's where the breast cancer risk is still tied to, right? Is the synthetic progestin. But there are, I would go to agestin, which is NIDA, norethindrone acetate. Or if they were younger, like a drospirenone, especially like if they peri or something.
Thank you.
Is that helpful?
Yes, thanks.
Yep. Okay.
Um,
Very helpful. And then there's a question in here, Carrie, as well about adding oral estrogen to an IUD for uncontrolled perimenopausal symptoms.
Yeah. And so the general answer is yes. And you can add any estrogen to an IUD for perimenopause. And that's really common. I think if you probably surveyed OBGYNs, you would find the overwhelming majority of OBGYNs are on that same sort of thing. It's the most commonly thing that I think people are on. But it doesn't have to be oral, but and you can. But again, it works best. IUD works best in that late period because remember, that's when we're seeing less ovulation likely because we're skipping. So we just have that we're taking away that more reliance on ovulation, and so using the IUD, which isn't going to stop ovulation, works better in that time. The other thing is if we're using an IUD as the progesterone alternate or opposite partner, whatever word I'm thinking of here, for estrogen, it's only used for 5 years and not your 8 years as contraception. So the levels that you need to balance out the estrogen are higher. It's only for 5 years.
Okay, really helpful.
And then back up, sorry, one thing I forgot to talk about is that back up to that progesterone question before. Although it's not in guideline, there are a lot of people and in smaller studies that if a patient is on greater than the equivalent of 0.05 estradiol 24 hours, then we would use 200. So if I have a patient, especially younger, like if I have them starting on a 0.075 or a 0.1, I will just start them off on 200 because it saves me the phone calls of bleeding.
Okay. Looks like
We all thought that would come into policy 2 years ago. That was presented at Menopause Society, some of that data, but nothing is, I mean, it takes 3 years to get something in writing for like that, but most of us do that, especially younger.
Okay, Carrie, I don't know if you saw it in the chat there. The follow-up question on the IUD. So
Okay.
using Mirena, Liletta are options. Can't use Kylena or Skyla.
You can't use Skyla. Skyla hasn't been shown for anything, and I wouldn't. Kylena is the equivalent of. It's only slightly less than Mirena and Liletta. And God, I don't have anyone on a Kylena. I will send you that. Menopause Society 2 months ago just had their thing on progesterone, and I don't want to misquote that, but I will send you that, Brianna. Sorry.
And I have a quick question. I Migley asked a question, I guess we can talk about
Oh, sorry.
this,
Yep.
this IUD, progesterone IUD, and using additional progesterone.
Yep. Yeah. Yeah. So you can. And actually a person on this morning. And so the question is really why, right? And so let's say I have an IUD and so the most common thing that you're going to hear about is adding it for sleep. Right. And so because again, the thought is that the prometrium will help for sleep. Again, has not been proven in the studies. We were pretty shocked on that outcome, but there is no doubt that most patients will tell us it improves. I mean, it's just the way progesterone works in our brains, right? And so we will see that. I also see sometimes for bridging, like I don't necessarily want to pull an IUD until I know something else is going to work or they have that. So I might have them keep their IUD while I try to find something else. And then because once you pull the IUD, then you've lost it. It's a really, not an unfun thing to put back in when it could have stayed in. The breast cancer team will tell you that they're worried about this as being too much progesterone. Because again, if we look at the studies, the breast cancer risk seems to be related to the progestogen component and specifically a progestin, of which, again, small observational studies with not the long-term data that we have of the WHI would not support prometrium has that same risk, but we are unsure. there is some European data that hopefully is going to be coming out that's going to look at it a little bit better.
And if this is going to take too long because we only have about 5 minutes left, like that's perfectly fine. But like another thing that kind of stresses me out is like these differences in dosing between perimenopausal and menopausal treatments, and then like where do we draw the line between where we make that switch? Like when do we decide, okay, well, you're not having menstrual cycles anymore, you're on OCP, but then we're supposed to be switching you to a lower dose long term, maybe for 10 years afterwards. Like where do we draw that line where perimenopause becomes menopause in those uncertain circumstances? And maybe I just don't know enough to even ask this question well.
I would say probably less important. Okay, so let's say, so the question probably comes as how much are we worried about contraception, right? And so if I have someone on an OCP, when do I switch over? Would that be a question? So if I have someone on OCP, and when do I switch them over? Menopause Society would tell us that 90% of patients are going to be through menopause at age 54 to 55, 54.7, so 55. So you can keep them on their oral contraceptive pill as long as there are no contraindications, and then I would switch them over at that time. That being said, so that if you have someone that, they can just switch over, like I have some 53, 54-year-olds, right, that want to switch over, you can just directly switch them over. Probably gonna have a little bit of bleeding just like and during that time period, see what happens, knowing that again, if they're going to go with like, our typical estradiol and micronized progesterone, that's not a contraceptive. They also can stop, wait 6 weeks, do blood test, and go from there. As far as doses go, I don't necessarily change my doses based on if they're peri or menopause, other than an oral contraceptive pill, ethinyl estradiol is much stronger of an estrogen than estradiol.
Okay, great. So I think we have time maybe for just one last question here. We got one in the chat around.
Sorry, wrong way. Okay. Yep.
I don't know if you can read that, Carrie, if it's helpful for us to read it out.
Yeah. Yeah. So it can be. So some of this can be. We're looking a lot of the impact of GLP-1. Again, if I had my workup and it was negative, I wouldn't do anything, per se. The question is there a polyp in there or not? I mean, I feel like I'm the polyp queen. There's a ton of polyps out there. As far as the combination patch, which is Combi Patch, it's the only combination patch available. There's Combi Patch or Combi Patch Pro. I find spotting on that I probably have less than 20 patients on that. And so I don't go to that with a concern of spotting. I feel like people that are on the Combi Patch started it for ease. So they want to remember one thing, and that's really, I mean, there are some other things. We haven't gotten into those other options, and we didn't get your question about options, Brandon, but if they come on it, I don't switch them, but I wouldn't go to that for bleeding. The next thing says add norethindrome. You could change. You don't want to add norethindrome to your prometrium. You want to stop the prometrium and then change them to norethindrome. 5 milligrams a day of agestin is best.
So this is just like amazing. Like I've learned so much. But there's still so much more that we have to go over, and which is like the crazy thing. And so that's why we're doing a 3-part series. And so we actually have Lauren Vessel coming in about 2 months to kind of talk.
Perfect.
Additionally, I think we'll get in more nitty-gritty exact doses, when to escalate, all of these things that like practically we really do need to know. And so we'll hit that there, because I'm getting like texts like, can you please ask this? And I'm just like, I'm so sorry.
Yeah.
But like this has been massively helpful. Thank you for coming. We truly appreciate your time. Thanks for delivering my 2 kids. We'll love that too. But yeah, we'll see everyone back in a couple of months, and please send me questions if there's any direction you want the 1 and 2 months to go, so that we can address things that people really want to hear about.
Yeah, I mean, I think the biggest thing is we love. I mean, like I saw menopause clinic this morning, and so this afternoon I have like three messages I need to send out to you know one has cancer, so I'm going to reach out to oncologists, and so I think the thing is, someone said, you as experts say, like, I am not an expert. Like, as I mentioned, like, I did not get trained in this. I just have an interest because my patients are, as we grow older, the same thing. And I really saw some of the really shitty things that are going on out there in these med spas. And so, we always love partners. We love when I mean, like, tell me really what you think about this cardiac risk assessment because I'm not that doctor, right? But I can help take what you tell me and then put it into a risk benefit discussion. But sometimes I need help. So so you had mentioned last things. What do you want from primary care? Is please reach out. We're always here. Send us messages. Please don't stop someone's hormones. Send us a message. Like I saw a patient, I think they need to be stopped. That is really helpful. We've had some kind of interesting, kind of weird, that's a really hard thing because then you have to be like, well, why in the hell did they do that? But you don't want to say that, right? And so if you ever think something, send us always a message. We're, I think, pretty good about responding. But always happy to answer any questions.
Yeah. Thank you so much. All right. Thank you, everybody. We'll see you
Yep.
back in a few weeks.
Thanks, guys.